So I think the reason we initially came up was because my wife's family has been coming up here for the last 35 years. Her grandfather actually lived in Charlevoix for 35 plus years. So we've been coming up here for 10 plus years. And my brother actually got married up here in 2019. So we've been coming up here for a number of years and we just love it. We love the people. We love the area. Obviously, we love the scenery, and it seemed like a good fit for us. So my name is Nicholas Coriasso, and I'm an interventional cardiologist at McLaren.
Could you share your educational journey, residency, fellowship?
So I graduated from medical school at West Virginia School of Osteopathic Medicine.
I'm so sorry.
Yeah, no problem. So I graduated from medical school at West Virginia School of Osteopathic Medicine in Lewisburg, West Virginia, which is southwest West Virginia. From there, I completed my residency at Henry Ford Hospital in downtown Detroit. I did my cardiology fellowship on the east side of Detroit at St. John Hospital, and I stayed an extra year to complete a year of interventional cardiology also at St. John Hospital in Detroit. So when I was in medical school, I did my clinicals in Charleston, West Virginia, at Charleston Area Medical Center. And when I did my subspecialty rotation for internal medicine, I got to work with an amazing cardiologist. And she kind of was the type that took the bull by the horns, and she really mentored me to a great degree in medical school, and that really made me fall in love with cardiology, not only in the cath lab but around the hospital and in the non-invasive world too. So I'm very passionate about complex coronary disease, whether that be with or without mechanical support. That was part of my training when I was in fellowship that I really do enjoy. Another aspect of my training that I got in Detroit that I really enjoy is peripheral disease, whether that be lower extremities, upper extremities, carotids. I really do enjoy peripheral arterial disease and peripheral vascular interventions. So the cath lab here offers a lot more than what you would think a kind of rural facility would. And what we have here, let me think of another way to say that. Okay. I can cut that one. So breaking it down from coronary and peripheral, with coronary, we have specialty equipment to assess the severity of the disease that patients have in coronary arteries, and we offer a image-guided service that allows for very limited contrast use to detect coronary disease, and that's what we have to offer in this lab. From a peripheral standpoint, with peripheral vascular disease, we offer an array of equipment to treat very complicated disease, from devices for atherectomy or specialty balloon angioplasty.
You know, one thing you said that was really cool, I liked how you said for a rural hospital or a hospital.
Yeah, okay.
If you could just kind of generally talk about
yeah.
It's pretty high end.
Yeah, no, I can. Sure. It was hard to tie that into like a very specific, treatment strategy.
Oh, sure.
Yeah, but I can give like a general.
That'd be cool.
Yeah. So whenever you're ready, I can go.
Yeah, go for it, Carla. Sure.
So this facility, for being a rural hospital and a rural cath lab, you wouldn't think that we have a lot of specialty devices and specialty items, but the staff here is very experienced, and they've worked with a number of cardiologists over the years and kind of built a base of specialty items that we have in this cath lab that you're not going to really see for 60 to 75 miles in any direction. So when you're talking about coronary disease, a patient comes into my office with chest pain, they end up with an abnormal stress test, then they're going to come and see me in the cath lab. So a typical procedure, I'm going to have the patient come in and they're going to get checked in by our nursing staff. From there, I'm going to come visit with them, do all of our checklists. The nurses are going to do all their checklists. The staff's going to do all their checklists, and we're going to get the patient into the cath lab physically. From there, we'll do a timeout just to make sure everything is kosher with the procedure, and then we'll give some mild to moderate sedation to make the patients feel comfortable. In most instances, we're going radial first, so we're limiting the amount of femoral catheterization that we're doing in the lab, and that's going kind of across the nation. So generally for left heart cath, we're going to get radial access, and if it's just a diagnostic procedure, sometimes it can be as short as 15, 20 minutes for the whole procedure. Now, of course, if you're going to have to intervene and put a balloon and put a stent in, that's going to be a bit longer, but generally doesn't exceed more than an hour and 30 minutes. From the time that's completed to the end of the procedure, usually what will happen is the patient will be coming down from sedation, and we'll remove the sheath. And generally for the wrist, we're going to put a pressure bandage on, and that's really the only major discomfort that the patient will have throughout the whole procedure. From there, they'll go to the recovery area, where usually they'll wait about 3 hours to get the band off and to just get a little post-procedural hydration with IV fluids. And 9 times out of 10, the patients will walk out of the hospital same day. So I had a patient, now it's been a few months ago, that luckily for him, he came into our emergency department at the right time, and I happened to be on call that day. And he was very, very sick when he came in, and they actually had called me when he was in triage. So I rushed up there to see him in triage really as they were checking him in, and he was having a massive heart attack complicated by cardiogenic shock. So luckily for me, this staff is incredible. So they were all prepared to handle this very complicated situation. We rushed the patient down to the cath lab. We put a specialty heart pump in to help with the cardiogenic shock, and we ended up putting stents in his left anterior descending artery, which was occluded at the ostial branch just near his left main coronary artery. With the pump being in place, I was able to do all this while maintaining his pressures, maintaining his hemodynamics, and he ended up doing very well procedurally, despite the fact that he was very, very ill. From the end of the procedure, he went to the ICU, and he stayed in the ICU for a few days. We got his heart pump out about a day and a half later, and he tolerated that very well. When I saw him in the ICU after we got the heart pump out, his wife had asked me, she said, we live in a 2-story house. Do you think he's going to be able to walk up to his bedroom because it's on the 2nd story? And I looked at her and I said, I just hope he can walk when he leaves the hospital. And sure enough, he got better and got better and got better. And I think he left the hospital only after 5 or 6 days being in the hospital, which is pretty remarkable. And I saw him in the office 2 weeks later, and he was dressed up in a full suit with a watch on and his rings on. He walked in no problems, and him and his wife both gave me a hug. So that was a pretty remarkable recovery from how ill he was when he came in.
I decided to come up here mainly because of the opportunity. It's a hospital with a great reputation for cardiology historically. And there was a lot of pathology in regards to the coronary disease, patient selection, variability. as well as my father is retired up here. So I decided to get a chance to spend some time with him and, pursue my career. So the region, I can talk more about that. In particular, the lifestyle was attractive with the landscape in terms of the hiking, the biking, the golfing, the skiing. So it was a community that we wanted to be a part of, a smaller community, not a lot of commute, not a lot of traffic, with an emphasis on lifestyle and health. So I'm Dr. Todd Michael James. I practice interventional and general cardiology here at Northern Michigan Medical Center. I think, is that what it's called? My name is Dr. Todd Michael James. I'm an interventional cardiologist and general cardiologist here at McLaren Northern Michigan Medical Center. I practice coronary angiography, interventional coronary interventions, as well as peripheral interventions and angiography, and pulmonary embolism extraction. Medical school is actually my third career. My original education was in architecture. I ran a design build company in Telluride, as long as with a service, sort of glorified service master corporate company. I then migrated back to school, where I went to medical school after a brief stint with professional ski racing. Once I finished medical school, in Chicago, I did my internal medicine residency in Blacksburg, Virginia for 3 years. Then I went to Northern Iowa, Mason City, and did my general cardiology fellowship. And then I migrated to Southern Chicago, Kankakee, where I did my interventional cardiology. I then took my first job in Phoenix, Arizona, where I worked for a private practice for 3 years with the emphasis on interventional cardiology, general cardiology office. And then went to Grand Junction, Colorado to help them establish an interventional cardiology program, and then ultimately here. I come from a family of cardiologists. My dad is a cardiologist, so I grew up around the cath lab and cardiology patients. I was rounding with my dad when I was just a youngster while he was on rounds on the weekend, so I was exposed to it early, and I was fascinated by the angiography and the heart as a organ system. Ultimately, when I was in residency, I sort of gravitated towards reading EKGs and hanging around the cath lab just to see what was going on. It was the most dynamic organ I could see. They were the smartest doctors. They were the most educated. And they did the most interesting procedures with the most immediate results. Ultimately, that's what I decided I wanted to spend the rest of my life doing, and pursued it from there. Northern Michigan McLaren Northern Michigan has historically, the Burns Clinic and the hospital before had a very, very good reputation for a strong, robust cardiology program, secondary to the patient population. It was considered a center of excellence, very academically based with research. So I'd heard about that and known some doctors that had practiced here. So initially that was a draw. And since I've been here, with the addition of the foundation that has been funding a lot of the program, with unlimited resources for the most part, unlimited amount of equipment, it allowed us to practice a very high level of cardiology with the up-to-date equipment and technology that any big academic center would have here in a small community. Was unmatched in my search. So I do coronary angiography, I do interventional cardiology, which is putting stents in coronary arteries. I do peripheral angiography, as well as doing angioplasty of lesions in the periphery, which would be the legs and the arms. And then I'm doing pulmonary embolism thrombectomy, which is pulling out blood clots from the lungs. I think that the most amount of success we get as interventionalists is when somebody is having a heart attack, the artery is completely occluded, their blood pressure is going down, their heart rate is going down, they're essentially dying. We bring them to the cath lab, we open up the artery, and everything changes. Their chest pain goes away, their blood pressure goes up, their heart rate goes up, they can finally take a breath, and it's instantaneous. So it's extremely gratifying to be able to provide that kind of care that quickly and that urgently with somebody who's that sick. It's also a relief when people come in with what we call angina to the office. We offer them an angiogram with a possible stent. They come down, they have a flawless procedure, and then they come back to your office thanking you because they don't have chest pain anymore and they can get back to their life and do the things that they were used to doing before. So those types of stories are what get me up in the morning and get me motivated to come to work. So in a community like this, where there's an older population, the acuity of their sickness is a little bit more, their hearts aren't as strong. So the ability to have the state-of-the-art technology allows us to work on older patients who are sicker, safer. Other facilities don't have the opportunity for this equipment, and these patients have to go to tertiary centers, whereas we can take care of them here with the assurance that the procedure is being done safely with the right amount of support. I think the most important thing to understand as patients is cardiology is a team sport, so to speak, where they are just as much responsible as we are. So if they get a stent or they get an intervention from us, the amount of work they have to do on their end is just as important in terms of taking their medications, making diet and lifestyle changes, and actually participating in their procedure. It's not something that we do to them, it's something that we do with them. And the better a partner they are, the better care and the better health they'll have. My name is Dr. Todd Michael James. I'm an interventional cardiologist here at McLaren Northern Michigan Hospital, specializing in interventional cardiology and general cardiology.
Perfect. Thank you.
Nailed it.
Obviously, it's a beautiful area. The nature here is amazing, and specifically this area with the ski hills and the ability to go out and do so many different things out in nature with the hiking and the beaches and the lake. It's just an amazing place to live, and I don't know why anybody wouldn't want to live here. My name is David Turnus. I'm a cardiologist here. My role at McLaren Northern is general cardiology, and I do transesophageal echocardiograms. I read non-invasive studies such as stress tests and echocardiograms, and nuclear studies such as cardiac amyloidosis scans. And I round in the hospital on the patients and see office patients. So, I went to medical school at Michigan State University, and then I did my residency and fellowship in the Detroit area at McLaren Macomb. It's called McLaren Macomb Hospital now. And then I did a an additional fellowship in Dayton, Ohio for interventional cardiology. So I have felt that cardiology was the peak of all medicine since my very first job working in a hospital when I was 19 years old. I was a transporter pushing people to their cardiology studies. And, you know, it was great at that time in that the cardiologists that I worked with kind of took me under their wing, and they showed me so much as this young kid that didn't know anything, and really they didn't have any reason to teach me, but they did anyway. And then I learned so much from them and just found it so exciting what you can do in cardiology to really help people, and really help a lot of people, because cardiology is what really helps so many people, because coronary artery disease and heart disease is so prevalent in our country. So that's really what drew me to cardiology. Okay. So what sets McLaren Northern apart, it does have a really good reputation for delivering quality care, and throughout the full gamut of medicine, especially cardiology, especially for an area here, further away from the city centers. Just that we can give the full gamut of cardiology care here is really enticing. I'm really passionate about evaluating for cardiac amyloidosis. It's something that is underdiagnosed dramatically, and we're really trying to increase the number of people we're screening for cardiac amyloidosis, because it actually is affecting a lot of people, and there are treatments out there for it now that we can really help people improve their quality of life for long term with that treatment. But we only treat that if we diagnose it in the first place. So cardiac amyloidosis is a cardiac health issue that involves deposition of abnormal proteins into the heart muscle, and then that causes the heart to not function appropriately, and it results in congestive heart failure, swelling in the legs, and shortness of breath, and inability to perform much activities. So it's something that is really important to treat, and that we have a treatment for it nowadays is just, we're so lucky to live at this time that we can actually do something for it. So people that are experiencing worsening shortness of breath with activity, swelling in their legs, actually there's an association with carpal tunnel. So if you have something like those symptoms, along with recently being diagnosed with carpal tunnel syndrome, then it might be something for them to be looked at. I won't be able to say one specific patient, but the type of patients that have had congestive heart failure and dramatically reduced heart function, we're able to treat that with a multitude of new medications that can really help improve their heart function. And very frequently with those medications and with close follow-up, we're able to get that so that their heart functions normally, and they're able to get back to doing all their things that they like to do. I would like to tell all the patients that the first person and the most important person in their health care is themselves. So the important thing is for those patients and those people to take care of themselves, stay active, to take their medications as prescribed, and to be aware of what symptoms they're having, so that they can let us know, and so that then we can try to treat them in the best way possible. But if they are not consistently aware of what their own symptoms are, then we can't help them as much as we could.
My name is Joel Engel. I'm a non-invasive adult cardiologist here in McLaren, Northern Michigan. And what drew me here was the area, first of all. I had some colleagues that I knew that were practicing here, who I've been in touch with for many, many years, and we had contact through the years, and they were always telling me, hey, you got to come up here. We have a great place here. We'd love for you to join us, et cetera, et cetera. And after having lived here in our vacation home for a while, I realized that this is where I wanted to be. The other thing about being here is that we have a very large drawing area with this hospital. We're a smaller hospital in size, but because of that large drawing area, we have to take care of these people. There's a lot of complex things that we take care of despite our small size. So we offer lots of advanced therapies from a cardiology standpoint that you really wouldn't expect to get from a hospital of this size. And that's exciting for me because you remain current with all the advanced technologies that way as a physician. Yeah, I went to a med school at Michigan State University. Following that, I went downstate to the Detroit area, did my internal medicine residency and then cardiology fellowship there. I just liked it. You know, people ask me that all the time, and it just inherently, I just enjoyed that specialty. You know, when you're in med school, you get bombarded with all these different areas of medicine, and it's good to be exposed to all of them, and you can make a decision that way. But as soon as I was involved in the cardiology system, I said, well, this is for me. I just enjoyed it. Yeah, well, I think that's it. You know, the hospital has served this area for many, many, many years, and people that live in the area have a special relationship with it because they know that when they're ill or when their relatives are ill, they're going to be coming here. And so there's a direct connection with those folks. They are just attached to our facility, and they expect that they will continue to get the high quality care they've gotten throughout all these years. So we're able to provide that. We need to provide that. We make an effort to provide that. If we were in a larger city, there would be other more tertiary centers, as we term them, that would be providing that kind of care that we really wouldn't have to do ourselves. But because we're the only shop in town, as it were, we have to make certain that we can provide that. And that's what we do. I think a couple of different areas. There have been a lot of advances over the last just few years with injectable medications that have really revolutionized the treatment of, say, lipid therapy, hypertrophic cardiomyopathy. A real hot topic these days is amyloidosis and the treatment. There have been drugs that have been developed recently that have really revolutionized that care. And the other area that I think has been very special is the percutaneous or minimally invasive treatment of valvular disease. We offer all of that here, and it's been a huge advance because people can recover so much easier with those kinds of therapies available. And really, as I said before, with the drug therapy, they are just so good compared to what we had in the past that it's just amazing the kind of results we get these days. And I think that's really going to become even more special as we move forward because with artificial intelligence, et cetera, there's going to be a lot of these things developed that are just on the horizon. We're involved in a lot of trials here in research at McLaren Northern from a cardiology standpoint, so we're always exposed to that, and as a result, a lot of our patients are eager, and if they're not so eager, they're at least willing to become part of our trials, and that helps a lot. So these are part of worldwide trials that we're involved with. So I'm heavily involved in the research aspect of things. There's some of us are principal investigators, others are secondary investigators, but yeah, most of us are involved in some way, shape, or form with the research that's going on. Yeah, I remember this is several years ago. We had a patient who needed a new mitral valve, and they had already had a valve surgery before, so they already had an artificial valve that was implanted many years that degenerated and was failing, needed a new one. And we told this person that, you know, we can do this here, It was another advanced therapy. He had had some exposure with the hospitals down Ann Arbor, Detroit. He says, well, you know, I know that this is sort of a new horizon for everybody. Maybe I need to go down there. And we said, well, you can do whatever you want to do, but believe me, we can handle this here. And he finally said, you know what, I'm going to let you do it. I think we just instilled some confidence in him. He trusted us, he believed in us. We did the procedure, very routine, very quick, and it really kind of changed this guy's life in terms of any of the symptoms that we were able to relieve for him. He was so super grateful, and it was just a heartwarming story for not only him but us, because everything just went so well. And we kind of convinced this guy, look, we can do that. Well, you know, we all have our interests, but we certainly have subspecialists that do certain work that maybe somebody else doesn't do. And so we have those team players that are around. They are very, very willing to get involved with these patients' care. They like to do that, especially if they're sort of a complex case, because it's more fun that way. You know, we all take care of sort of the, I don't want to say mundane, but the common things happen commonly. But when the things that aren't so common happen, it's fun to get involved in that. And so we have several different subspecialists in cardiology that are available to us right here on staff that we can go to and say, hey, this is a special person, this is a special case, this is a special problem, what are your thoughts? And it's great to have that backup, because nobody can know everything. Sometimes people that we meet for the first time have never had a problem with their heart. They are new to this journey, and they really never thought they'd have a problem with their heart. It's all brand new to them. So we need to educate them. And we may be starting from absolute scratch, from zero. And a lot of times we are. And you know, if you've had a serious heart issue, it's scary. It's very, very scary for people to go through that, especially if they need to, say, have surgery or an advanced procedure. So we need to help them get through that journey. Part of the journey is getting better, is rehab. And of course, we have cardiac rehab here. And we offer that to everybody. Everybody really, we'd like them to become involved in that and take all that information that they derive from having cardiac rehab home with them after they, quote unquote, graduate from the program, so that they can remain healthy. You learn a lot in cardiac rehab. But I know just personally myself, I'm always harping on things that people need to do to remain healthy, and it's really pretty easy. Diet, exercise, taking your medications, listening to your body, getting fit, making sure that you stay in touch with your doctors, whether it's me, one of my associates, or even your primary care provider is very, very helpful as well. You know, it doesn't stop there. So those are a lot of kind of the things that we emphasize with folks. So, yeah, my family and I were on a vacation. This was probably close to 20 years ago, and we had really never been to this area, so we were here, and we just loved it. It was just beautiful. It was just really what we all enjoyed. And after the vacation, my wife and I were talking, and said, you know, we really need to have a place up there. So to make a long story short, we ended up buying a vacation home, spent a lot of time up here. Of course, I knew several people that were in the practice here, and they were telling me, look, you know, you love it here. Why don't you think about just moving up here and becoming one of our associates? And, you know, initially I kind of put it in the back of my mind, because we were well situated where we were, but over time that idea really took hold, and it really sounded like a great opportunity. And when an opportunity did arise where I could join the group, I just went for it and never looked back. Love it up here, love working here. I can't imagine being anywhere else. It's just a wonderful place to live and work.